Bismillahirrahmanirrahim. So now we are going to start with the pityriasis versicolor or the tinea versicolor. That is a fungal condition that is caused by the Malvasia species. The most common of them is Malvasia furfur, and other species can also be involved. So let's see that. Presentation is hypopigmented or hyperpigmented or erythematous macules or patches on the upper body. So macules is less than 1 centimeter, patches is more than 1 centimeter, but both of them they are going to be flat things, right? Okay. So they can either be hypopigmented or hyperpigmented or erythematous. There is no hard and fast rule in the case of pityriasis versicolor. It is common in the areas with hot and humid climates and is often most visible after the extensive sun exposure due to tanning of the adjacent skin. So that is like it is very common in the Pakistan, India, or maybe in the area like Bangladesh or Sri Lanka where we have humid environments. So in the humid climates, it is very common. Along with that, excessive sun exposure due to tanning of the adjacent skin. So basically, you can say any Asiatic country has hot and humid climate. So the pityriasis versicolor can develop in those areas. Uh, and you might also have developed this condition sometime in your life because it is not very dangerous or something condition. That's just a normal skin condition caused by Malvasia species yeast, and the infection is confined to the stratum corneum. The diagnosis is made by potassium hydroxide preparation of the skin scraping. Malvasia forms spores and hyphae, producing the characteristic spaghetti and meatball appearance on the light microscopy. The hyphae have short cigar butt appearance. Okay, so cigar butt appearance, I guess it came sometime before, but remember that cigar shape or cigar butt appearance, they're not going to ask you about that because the cigar shaped yeast is a very characteristic or classical word for Sporocytic Schenkii because those yeasts are very cigar shaped. The cigar butt appearance is a small cigar, maybe. So, but the spaghetti and the meatball appearance is the characteristic buzzword for the pityriasis versicolor treatment. Topical antifungal agents and selenium containing shampoo. The Selsun Blue shampoo, if you have ever used that, so that contains the selenium and that is used for the treatment of one species of the pityriasis versicolor that affects the hair and that is called as dandruff. So, for the treatment of dandruff, we are using selenium containing shampoo. So, here you can see the hypopigmented spots, and here in this picture here there are hyperpigmented spots. They are not very uh, they are not they're not itchy, so they are not associated with any significant pruritus. Then we'll talk about nevus or mole, benign neoplasm of melanocyte. For example, over here you can see nevus, that is a benign neoplasm. Nevus, remember, that is a neoplasm of the melanocytes. Congenital nevus, present at birth, often associated with hair, in contrast with the melanoma that have no hair growth with it as it destroys the hair follicle skin. Okay, so melanocytes, the congenital nevus is associated with the hair. Here you can see in this picture that hair are present around it. In this congenital nevus, hair are present, and that is a contrasting thing from the melanoma that have no hair growth and the melanoma will destroy the hair follicles. Acquired melanocytes or nevus, that is a common mole caused by activating mutation of the RAS signaling pathway, BRAF or NRAS. So it's a common mole caused by acquired activating mutation of the RAS signaling pathway, BRAF or NRAS. Types: intradermal nevi, junctional nevi, and compound nevi. So what are intradermal nevi? Melanocytes within the dermis. Most common mole in the adults, that is papular. So in the picture F you can see this is the papular mole, and that is found most commonly in the adults, and melanocytes are within the dermis. In the junctional nevi, the flat macules, non-hairy, pigmented aggregates of the cell grow along the dermoepidermal junction, basal layer only. Most common mole in the children. And the compound nevi, so the one shown here, they are most common in the children, and these are junctional nevi. Junctional means that flat macules, non-hairy, pigmented aggregate of the cell growing in the dermoepidermal junction. So at the junction, okay, listen. If it is intradermal, melanocytes within the dermis, that is most common mole in the adult. So let's see the skin layers. Okay, let me bring it over here. So just give me a second. So let's go to the page. So if the melanocytes, okay, here you can see, yep. So if the melanocytes are present in the dermis layer, like this layer, so they are more common in adults and they are called as intradermal nevi. If they are at the dermoepidermal junction, like this is epidermis over that and below this pink line, below the stratum basale, we have epidermis. No, above that we have epidermis, below that we have dermis. So they are called as junctional nevi. And for the compound nevi, the feature of dermal and junctional part of melanocytes within the, okay, give me a second. So what is the thing with the compound nevi? There are features of dermal and junctional, both features are present, like part of the melanocytes within the dermis and other parts within the dermoepidermal junction. They are called as compound nevi. They grow into underlying dermis as nest of cords of cells, and the beard of dome shaped, less pigmented than junctional nevi. So they're less pigmented, like over here you can see this is the compound nevus. Okay, so this can be confusing. So in adults we have intradermal nevi, like the melanocytes are deep into the dermis and they are not pigmented, they're just the papular type of lesion, like they are elevated skin lesion which are less than 1 centimeter in their size. The junctional nevi are present in the dermoepidermal junction. They will be pigmented. On top of that, they are like what's that? So they are going to be macular in appearance, I guess. Yeah, they're flat macules. So the junctional nevi are flat macules, while the compound nevi, as you can see in this picture, they are less pigmented and they are dome shaped. Okay, so they're dome shaped, so they can either be papules or maybe papules or plaques. So whatever it is, but the dome shaped one is the compound nevus, and the other one are intradermal and blah blah blah. So remember these things, and now we'll move forward. So to this picture, histology of nevi. So this is a picture over here. Now you can see that nevus cell melanocytes without the dendrites, okay. The transparent epidermis is over them, and then normal melanocytes are present like this. And if the melanocytes are not having the normal dendrites, so they're increased in number, so they are the nevus, okay. Then the dermis is below that. Junctional nevi are present at the dermoepidermal junction between at the junction of dermis. This is dermis and this is epidermis. So if the nevus is present on the junction, that is called as the nevus cell, okay. Then the compound nevi, the cells are present inside the dermis, okay. So if the melanocytes are intradermally present, they are called as compound nevi. No. Give me a second. So if they are present on the dermoepidermal junction, they are called as junctional nevus. If it is present only inside the dermis, that is called as intradermal nevus. And if it is present on both the sides, like some of them are present on the junction while some are inside the dermis, so that is called as compound nevus, like the compound of both of these things, okay. So remember these things. And the junctional nevi are more common in the children. They will be appearing as macules. The intradermal nevi are more common in adults and they will appear as papules, while these things can appear as a dome shaped appearance thing, can be a papule, can be plaque, okay. Then moving forward to the dysplastic nevus, flat macules, slightly raised plaques or target lesions. They can be anything in between. They can be flat macules or slightly raised plaques or target like lesions, slightly larger than most acquired nevi, more than 5 millimeters, distinguished by size, pigment variation, irregular borders, possible melanosome precursors, and reside in both dermis and epidermis. Dysplastic nevus syndrome, dozens to hundreds of melanocytic nevi on non-sun exposed skin, trunk and upper extremities. Autosomal dominant, dysplastic nevus syndrome is autosomal dominant and very high risk of melanoma. There is very high risk of melanoma associated with that. Seborrheic dermatitis, erythematous, well demarcated plaques with greasy yellow scales in the areas rich in sebaceous glands such as scalp, face, and periocular region. Sebaceous glands are not inflamed but play a role in the disease development. Common in both infants and adults associated with the Parkinson's disease, possibly associated with the Malseria species, and treat with the topical antifungals and corticosteroids. So talking about seborrheic dermatitis, we have to treat them with antifungals and the corticosteroids, and they may be associated with the Malseria species. Okay, so this is seborrheic dermatitis, all of them. Now we'll talk about common skin disorders. Firstly, we'll talk about acne, that is very common. So chronic inflammation of the hair follicles and associated sebaceous glands. Chronic inflammation of the hair follicles and the associated sebaceous glands. Hormone associated increase in sebum production. Sebaceous glands have androgen receptors, and keratin production blocks the follicle, forming the comedones. Okay, we'll see that. But remember, the chronic inflammation of the hair follicle and associated sebaceous glands with a hormone associated increase in the sebum production. Sebaceous glands have androgen receptors and keratin production blocks the follicle, forming the comedones. Propionibacterium acnes infection. So Propionibacterium acnes, that is an organism. Infection produces lipases that break down the sebum, releasing pro-inflammatory fatty acid, result in the pustule or nodular formation. So let me see what is the meaning of comedones. So comedones are stuff like that, like the blackheads maybe, they are called comedones. So comedones are small flesh-colored white or dark bump that give skin a rough texture. The bumps are caused by acne. They are found at the opening of the skin pores. A solid core can often be seen in the middle of small bump. Open comedones are blackheads and closed comedones are whiteheads. So if the comedones are open, they are called as blackheads, and if they are closed, they are called as whiteheads. So what about that? The hormone associated increase in the sebum production. Sebaceous gland have androgen receptors. And B, keratin producing production block the follicle. So the keratin production is enhanced. The sebaceous gland or the hair follicle will be blocked, and that will result in comedones. Propionibacterium acnes infection. So I guess there is some picture about that as well. Okay, so there must be a picture because there was a Uworld picture about that. We'll see that when we do the Uworld sessions. So propionibacterium acnes infection produces lipases that break down the sebum, releasing the pro-inflammatory fatty acid, result in the pustule or nodule formation. They are characterized by these three things: comedones, pustules, and nodules. What are comedones? Comedones are small bumps, papules, frequently found on the forehead and chin of those with acne. Open comedones are blackheads, black because of the surface pigment melanin rather than dirt. And closed comedones are whiteheads. The follicle is completely blocked. So if they are open, they will appear as blackheads because of the surface melanin pigment, and if they are closed, they are like whiteheads. The follicle is completely blocked. Then pustules or pimples. Pustules are the vesicles with pus in them. So that is why their pustules or nodules can also appear. They have a multifactorial etiology. So multifactorial etiology means that follicular epidermal hyperproliferation by androgens, excess keratin production will be seen. So in the case of follicular epidermal hyperproliferation by androgens will lead to excess keratin production, excessive sebum production or androgens, inflammation, for example, papules, pustules, nodules, or cysts. Cutibacterium, that's a very cute bacterium, formerly called as propionibacterium acnes, colonization of the pilosebaceous unit, comedones. Bacteria produce lipase which convert the sebum to inflammatory fatty acids. Then we have drug causing the acne, steroid, androgens, and anabolic steroids, epidermal growth factor receptor inhibitors, and lithium. Okay, so multifactorial etiology. So drug causing the acne, steroid, androgen, and anabolic steroids, epidermal growth factor receptors, inhibitors, and lithium. So these can cause the acne. Steroids are very important because they are highly tested upon concept. The gymmers or the pro athletes who use steroids for development of their big muscles, they can develop acne because of increased level of androgen and anabolic steroids, epidermal growth factor receptor inhibitors, and lithium. Treatment include retinoids, that is vitamin A isotretinoin, decrease keratin production, decrease size of sebaceous glands, and inhibit the sebum production. Contraindicated in pregnancy. The retinoids are contraindicated in pregnancy because they are teratogenic. A negative pregnancy test, urine or serum, is required prior to prescribing, and abstinence contraception is recommended. So when you're giving vitamin A, firstly test the mother for a negative pregnancy test. Secondly, when the timeline through which you are giving the vitamin A, in the same timeline the mother should also use the oral contraceptive pills so that she does not get pregnant in that timeline, because the vitamin A is very teratogenic and it can cause serious problems with the fetus. So that is why we have to give oral contraceptive in that period of treatment. Sexually active women should be advised to use 2 forms of contraception and take monthly pregnancy test. Benzoyl peroxide, antimicrobial, and antibiotics tetracycline. So these are the treatment of choices for the acne. We can use benzoyl peroxide, that is antimicrobial, and antibiotics specifically, that is tetracycline, that is used. I guess that is used to kill the propionibacterium or the Cutibacterium acnes. Then this is the mechanism of action of the mechanism of action of the retinoid is that retinoid has receptors inside the cells or intracytoplasmic receptors. So retinol will enter, it will be converted to retinol will be converted to retinoic acid. Retinoic acid will bind to the cellular retinoic acid binding protein. That cellular retinoic acid binding protein will take the retinoic acid into the nucleus, where it will bind to the RXR and RAR. I don't know what that means, but retinoic acid receptor blah blah something rare. So basically it performs its function intracellularly, decreases the sebum production, normalize the epidermal differentiation, and increases the cell turnover. They increase the cell turnover, normalize the epidermal differentiation, and decrease the sebum production. These are the 3 main actions which are done by the retinol administration. We need a decreased sebum production because in acne that is the main culprit. The normalization of the epidermal differentiation, are that good enough? And increased cell turnover. I guess this is not playing any important role, any significant role in the case of acne, but it is very important for a acute myelocytic leukemia or some other disease conditions. This is a picture of a person who is having acne. Then moving forward to the atopic dermatitis or eczema presentation. Pruritic erythematous oozing rash with crusted lesions. So it is pruritic erythematous or oozing rash with the crusted lesions. This condition is chronic. This condition has a chronic course marked with exacerbation and remission. The severity of the disease tends to lessen with age. Intense pruritus is a hallmark of atopic dermatitis, and the diagnosis cannot be made without it. Commonly on the skin flexures, the atopic dermatitis is commonly found on the skin flexures. Often appears on the face in infancy. Atopic dermatitis. We're talking about eczema. So eczema appears on the face, like this is the person who is having, there's a child who is having eczema on the face, and then later on it will go to the flexor surfaces, skin flexures, in antecubital fossa in children and adults. So in children and adults, the eczema develops in the cubital fossa, while in the very small child, that will develop on the cheeks. So that is also called as atopic dermatitis. Often appears on the face in infancy and in the antecubital fossa in children and adults. Lichenification or in a flexure distribution. So what is lichenification? Which layer is involved in the lichen planus? Lichen planus was involving the I don't remember it now. Let's see that. Lichen planus is involving lichen planus. I guess it was here. No, it's not here. Lichen planus. Okay. So the lichen planus is involving the hypergranulosis, the zona glomerulosa, stratum granulosum is being involved in the case of lichen planus. So now they're in the atopic dermatitis, they're saying the lichenification of what? There will be lichenification of the flexure distribution. For example, neck and the wrist and the antecubital and the popliteal fossa. Antecubital is like in front of your elbow. The normal cubital fossa is the antecubital fossa, and popliteal fossa is the one which is behind your knees. So these are the two fossae. And along with neck and wrist, which are flexor surfaces, they may develop the atopic dermatitis. It is a type 1 hypersensitivity reaction. It is triggered by various environmental factors such as ingestion of certain foods or exposure to certain environmental irritants. It is associated with other atopic diseases, for example, asthma, allergic rhinitis, and food allergies. Increased serum IgE, peripheral eosinophilia, and high level of CAMP phosphodiesterase in their leukocytes. So there will be increased level of serum IgE, peripheral eosinophilia, and high level of cyclic AMP phosphodiesterase in the leukocytes. Pathophysiology: mutation in the flagrin gene, epidermal protein, breakdown in the barriers between the epidermal skin cells. So the atopic dermatitis is due to the deficiency of the flagrin gene. The pathophysiology is the mutation in the flagrin gene, that is epidermal protein, breakdown in the barrier between the epidermal skin cells, dehydration of the skin, as well as the ability of the aeroallergens. Okay, so dehydration of the skin as well as the ability of the aeroallergens like the pet dander and the dust mites to penetrate the skin, that will result in immune hypersensitivity. Okay, so flagrin epidermal proteins will cause the breakdown of the barrier of the skin between the epidermal skin cells, dehydration of the skin as well as the ability of the aeroallergens like pet dander, dust mites to penetrate the skin. So basically the flagrin gene is allowing the allergen to enter the serum or be exposed to the immune system of the body. So normally the flagrin gene will not allow the allergens to enter the skin. If there is mutation to the flagrin gene, the allergen or any substance will enter the skin first, and then it will be exposed to the immune system. Then type 1 hypersensitivity reaction will be mounted against that, and resultantly will have atopic dermatitis, that is also called as eczema. Now we'll talk about allergic or contact dermatitis. It is a type 4 hypersensitivity reaction. Type 4 hypersensitivity reaction. The presentation is pruritus, erythematous, pruritic. It is like very itchy, erythematous, oozing rash with vesicles and edema. Lesions occur at the site of contact. For example, nickel. Nickel is basically associated with the cheap jewelry which the girls often wear in the ear. So that results in the contact dermatitis. And poison ivy. Poison ivy is coming from some tree bark, and neomycin is an antibiotic. So these are the things that commonly cause contact dermatitis, or which are commonly asked on the step 1 exam. So these are nickel, poison ivy, and neomycin. Pathophysiology: due to the exposure to allergens, type 4 hypersensitivity reaction, antigens are taken up by the antigen presenting Langerhans cells and presented to the CD4 positive T cells in the regional lymph nodes. The T cells are activated and migrate to the skin, where they incite an inflammatory response within 24 hours of the antigen re-exposure. That is very important point. The antigen re-exposure is going to cause the inflammatory reaction in both the cases. Like in atopic dermatitis, the re-exposure is causing the disease. Even in the case of allergic contact dermatitis, it is the re-exposure of a particular antigen that will be causing the disease. Examples of allergen: poison ivy and nickel jewelry, irritant chemicals, for example detergents, and drugs, for example penicillins or maybe neomycin, they are causing the disease. Histology: in histology we will find spongiosis. What is spongiosis? An accumulation of edema fluid in the intercellular spaces of the epidermis is called as spongiosis, in contrast with urticaria, that is edema of the epidermis and the superficial dermis. With chronic exposure, lesions become less edematous, the thickening of the stratum spinosum and stratum corneum. So what's that? D and D. So nickel exposure, as you can see that the belt buckle is of the nickel, so exposure of the skin around that is causing the contact dermatitis, and E is for the neomycin. So I guess there was some cream, neomycin cream is applied topically. I'm not sure. That is an aminoglycoside, so that may be given for some allergy, not allergy, for some infection. So we gave neomycin cream to that person, and then he developed this kind of reaction. So that is basically hypersensitivity reaction or allergic contact dermatitis associated with the neomycin. Then it is earth oil induced contact dermatitis. It is an example of contact dermatitis. Earth oil is present in some tree barks or maybe some perfumes or fragrances maybe. So but earth oil induced contact dermatitis, the mechanism of action is like that. Firstly, we'll have a sensitization phase in which the earth oil will enter the skin. Langerhans cells will take up that antigen. They will go to the nearby lymph node. The afferent lymph node will receive these antigen presenting cells, and they will be stimulating the CD4 positive T cells, Th helper type 1 cells, and CD8 T positive, which are cytotoxic T cells. Then from the efferent lymph node, these type of cells will go and dwell the skin layer. They will come under the skin. This is the sensitization phase. In the elicitation phase, when the re-exposure of that particular earth oil antigen or some other antigen, for example nickel or some pet dander, nickel or poison ivy or neomycin takes place. So what happens that these cells with these antigens will then be detected directly by these CD8 positive T cells and CD4 positive Th1 cells. So CD8 positive T cell induce keratinocyte apoptosis, and release of inflammatory mediators will result in a picture which looks something like this. So this is a picture of contact dermatitis after the exposure to the or re-exposure to a particular antigen. Prevalence of poison ivy, oak, and sumac in the US. So listen, the locations, the USA map, you must remember the map, and you must remember it for the fungal infection because that is very important for that. I don't know if it is important for this or not, but let's see it. So the green areas, okay. So the very green areas for the poison oak, then so these states, and yeah, these states only. So these are I don't know how to. So here we have the compass. I have taken the help of my younger brother who is like pro in that. I always mess these things up. So here we have the east, west, north, and south. So in the western, or you may say southwestern states, the poison oak is very important. The poison oak, the prevalence of poison oak hypersensitivity is more common. The poison ivy, which is like in these states, the central United States, these people, the people who live in these states, they have poison ivy hypersensitivity. Poison ivy and oak, both hypersensitivities are present in these conditions, which are like the southeastern states, maybe, yeah, southeastern, that comes out to be that. Poison ivy and sumac, these states, like now these ones, these are eastern and northeastern states. They have sumac poisoning, and poison ivy and oak poisoning, which are like extreme southern states. In Southern America we have the not Southern America per se, but in the southern states of United States we have poison ivy and oak and sumac. So remember it if you have too much brain space, but I don't think that it is important. It is poison ivy, and this is something that poison oak is there, and poison sumac, okay. Then we have Uworld point, local cutaneous adverse effect to the chronic topical corticosteroids. So local cutaneous adverse effect to the chronic topical corticosteroid administration include atrophy and thinning of the dermis that is associated with the loss of dermal collagen, drying and cracking and or tightening of the skin, telangiectasias or ecchymosis. So this is something, the adverse effect which is associated with the topical corticosteroid consumption. Moving forward to the atopic eczematous dermatitis, genetic mutation in the flagrin gene. So in the atopic, so let's differentiate those both two kind of autoimmune dermatitis. The first one is atopic or eczematous dermatitis. Genetic mutation of flagrin gene, okay, it is a type 1 hypersensitivity reaction, and skin flexures, for example face and antecubital fossa, is most commonly involved. In contact dermatitis, reaction to a chemical exposure directly to the skin It is a type 4 hypersensitivity reaction, and anywhere at the site of chemical exposure will cause contact dermatitis. Now we'll talk about pseudofolliculitis barbae. Barbae is something associated with the beard, and it is pseudofolliculitis barbae. Commonly occurs as a result of shaving, that is razor bumps or shave bumps. These are the classic picture. This is not a classic picture. This is a classic picture. After a hair has been shaved, it begins to grow back. Curly hair tends to curl into the skin instead of going straight out of the follicle, leading to an inflammatory reaction, foreign body inflammatory reaction. Okay. Then, so the curly hair, then this must be common among the African races maybe. So primarily affect the African American males who have curly hair or curly beard hairs, characterized by firm, hyperpigmented papules and pustules. Papules, they are small, elevated lesions, and pustules, these are vesicles filled with the pus that are painful and pruritic, located to cheeks, jawline, and neck. So that is pseudofolliculitis barbae. Then we'll talk about psoriasis. Presentation: well circumscribed salmon colored plaques with silvery scale, that is psoriasis. Silvery scaling is very important buzzword for the psoriasis. Then usually on the extensive surfaces of the scalp. Then we have this sign that is called as Auspitz sign. Pinpoint bleeding spots from the exposure of dermal papillae when scales are scraped off. That is Auspitz sign. There is no picture of that Auspitz sign. Auspitz sign. Let's see a picture. Auspitz sign. So the Auspitz sign is pinpoint bleeding under the skin surface. It typically occurs after scratching the psoriasis plaques or other form of skin scales. So let's see the Auspitz sign. It is looking something like this. So there will be pinpoint bleeding inside the skin. That is Auspitz sign. As you can see, these are the sites of spots of bleeding inside the skin. These ones. Coming back, the Auspitz sign is positive. Pinpoint bleeding spots on the exposure of dermal papillae. From the exposure of dermal papillae when the scales are scraped off. Complications: psoriatic arthritis, nail changes which are yellow-brown discoloration, pitting, thickening, or crumbling, inflammatory disorder of the eye, conjunctivitis, blepharitis, or uveitis. Pathophysiology: due to excessive keratinocyte proliferation, possible autoimmune etiology associated with HLA type C, and lesions which often arise in the areas of trauma, environmental trigger. Lesions arise in the areas of trauma. Okay, so lesion. Okay, I'm sorry. So lesions arise in the areas of trauma, environmental trigger. Then we'll talk about skin biopsy in case of psoriasis. Firstly, we'll have acanthosis. What is acanthosis? It is epidermal hyperplasia, or acanthosis means that there will be increase in amount of the keratinocytes in the stratum corneum. So that is acanthosis, increased epidermal hyperplasia. Okay, then parakeratosis, hyperkeratosis with retention of the keratinocyte nuclei in the stratum corneum. So here you can see that this is parakeratosis, in which the keratinocytes on the upper layer have the retention of the nuclei. Then increased stratum spinosum and decreased stratum granulosum. In the psoriasis, we have increase in amount of stratum spinosum. Stratum spinosum, they have not picturized that, but stratum spinosum is increased in number, and the stratum granulosum will be decreased. So the mnemonic was come, let's have sunburn. So come, let's have. Okay, I'm sorry. Let's see the mnemonic. The mnemonic was over here. So the mnemonic was come, let's get sunburn. Okay, so the outermost layer is corneum, then lucidum, then granulosum, and spinosum. So we are saying that spinosum is increasing in number. So if the spinosum is increasing, you may remember it like that. If spinosum is growing upwards, so it is compressing the granulosum which is residing up above it. So the granulosum will thin out, while the spinosum will increase in number. And then stratum corneum, the corneum layer is also increasing. The corneum layer is increasing. There was something about that maybe. Okay, let's forget about it. Yeah, let's move forward. So the spinosum will increase in number, while the granulosum will decrease. The stratum granulosum will decrease. Then neutrophils within the epidermis, spongiform pustules, okay, and stratum corneum, Monroe microabscesses. So we'll find neutrophils in the case of psoriatic arthritis in two areas. First one is epidermis, and second one is stratum corneum. If they're present in the epidermis, diffusely in the epidermis, so they're called as spongiform pustules, and if they're present specifically in the stratum corneum, then they're called as Monroe microabscesses. So here you can see Monroe microabscesses, and then we'll talk about the elongation of the dermal papillae. The dermal papillae, which were like this small, they have elongated all the way like this, down and above and down and above. So they are elongated. Elongation of the dermal papillae, thinning of the epidermis above elongated dermal papillae. No, thinning of the epidermis. Okay, so there will be elongation of dermal papillae, and the epidermis which is above that will become thinned out. It results in the bleeding when the scale is picked off. Osprey sign. Okay, Osprey sign is positive because of thinning of the epidermis and this what's that, elongation of the dermal papillae. So here you can see parakeratosis and microabscesses, dilated and tortuous capillary loops, irregular thickening of epidermis, and upper dermal T lymphocyte infiltrate upper dermal T lymphocyte are infiltrating the limb. The treatment involves corticosteroids. Okay, then PUVA, it is some UV light exposure or something, UV light, UVA, to destroy the proliferating keratinocytes, and with pores, what's that, soralen, what I can't pronounce it, PSORALEN, so soralen to increase the UVA absorption. Okay, some soralen is something, so let's see PUVA, what's that, PUVA means some UV light therapy. So PUVA means a combination therapy with the drug soralen. Okay, so P means soralen, and then exposing skin to a long wave ultraviolet light. UVA means somehow it means long wave ultraviolet rays given along with soralen. So what is soralen? Soralen is basically a substance from the plant that is sensitive to light. So we give soralen along with the UV light, which is long wavelength UV light. So we give the UV light therapy for the patient of psoriasis. First one is corticosteroid, then PUVA. Along with that, we give the topical vitamin D analogs. Why do we give that? We give topical vitamin D analogs. Include the calcipotriene or calcipotriol, calcitriol, and tacalcitol. Okay, these are very horrible names. Calcipotriene, calcitriol, and tacalcitol. These medications bind to and activate the vitamin D receptors, a nuclear transcription factor that causes the inhibition of keratinocyte proliferation and stimulation of the keratinocyte differentiation. Treatment with the vitamin D analogs have also been shown to inhibit the T cell proliferation and other inflammatory mediators. Okay, then immune modulating therapy. We can use cyclosporin, that will decrease the level of interleukin 2. Etanercept, that will decrease the TNF alpha because it is a decoy receptor. Okay, then methotrexate. Methotrexate decrease the dihydrofolate reductase. What's that? Dihydrofolate reductase, THF reductase. Okay, methotrexate. Okay, pardon me. Methotrexate is dihydrofolate reductase, which will not allow the conversion of dihydrofolate into tetrahydrofolate. Decrease the rapidly proliferating epithelial cell in the skin. Okay, I guess we'll give topical methotrexate for that, because methotrexate is a toxic drug. We use that in the anti-cancer therapy and stuff like that. So if we give it, so that can be used in the treatment of psoriasis. Then ustekinumab, that is Stelara. Ustekinumab is a human monoclonal antibody used in the psoriasis that targets the interleukin 12 and interleukin 23. It inhibits the differentiation and activation of CD4 positive Th1 and Th17 cells. What is rosacea? Inflammatory facial skin disorder characterized by erythematous papules and pustules. Papules are like just elevations, and pustules are those lesions like pus-filled vesicles, but no comedones. So rosacea is a condition in which we have erythematous papules or pustules but no comedones, may be associated with a facial flushing in response to the external stimuli, for example alcohol or heat. Pimaceous rosacea can cause rhinophyma, bullous deformation of the nose. So rhinophyma is a very big tumor of the nose. So pimaceous rosacea can cause rhinophyma, bullous deformation of the nose. Let's see the picture of rhinophyma. So this is the picture of rhinophyma. Rhinophyma looks something like this. Like this is a enlarged nose, and it looks like a rhino nose. Okay, so that's rhinophyma. Now coming back to the picture. So pimaceous rosacea is associated with rhinophyma. It's a very dry knowledge. So derma is always very dry. So remember it if you need to. Then moving forward, we have seborrheic keratosis. It is high yield. So seborrheic keratosis is flat, greasy, pigmented squamous epithelial proliferation with keratin-filled cysts, horn cysts. Okay, so there are horn cysts in that, as depicted in the picture K. Okay, so there are cystic development inside this flat, greasy, pigmented squamous epithelial proliferation. What is seborrheic? Seborrheic keratosis. Seborrheic keratosis is flat, greasy, pigmented squamous epithelial proliferation with keratin-filled cysts or horn cells. So these cysts are filled with the keratin. They look stuck on. Lesions occur on the head, trunk, and extremities. So here somewhere in this is on the trunk, and it can also develop on the extremities. Common benign neoplasm of the older persons caused by FGF23 activating mutations, receptor tyrosine kinase. They are seen with a lesser trillate sign. Seborrheic keratosis are present in the lesser trillate sign. So sudden appearance of the multiple seborrheic keratosis, part of paraneoplastic syndrome indicating an underlying malignancy, for example, the GI or lymphoid malignancy is present. In that case, we can develop lesser trillate sign, that is basically a seborrheic keratosis. So here in this histological picture, you can see that this is a seborrheic keratosis picture. I guess it is a picture from pathoma, and these are cysts from which are filled with the keratin. Okay, these are keratin filled cysts inside a greasy flat, not flat per se, but greasy and pigmented squamous cell epithelial proliferation. Then what is verrucae? Verrucae are warts caused by low risk HPV strains like I guess 1, 4, 6, 12 or 11, 6, 11. Okay, so these are the strains which are causing verrucae. Soft, tan colored, cauliflower like papule. As you can see, these are on the fingers and these are on the glans penis. Then epidermal hyperplasia, hyperkeratosis and coilocytosis. Condyloma acuminata on the anus and genitals is also an example of the verrucae. Then moving forward, we'll talk about urticaria. Urticaria is hives which is seen in the allergic reactions or anaphylaxis. So pruritic wheals that form after the mast cell degranulation. Here you can see the urticaria over here or maybe here. So these are the pruritic wheals which are formed after the mast cell degranulation. Histology will show superficial dermal edema, no epidermal changes and lymphatic channel dilation. Okay. Then let's talk about skin wrinkles. How the skin wrinkles form? We're going to talk about the aging of skin. Risk factor: ultraviolet light, UVB wavelength, sunburn, and increased risk of malignancy. UVA wavelength. So that is basically UVA wavelength which we give in the treatment of psoriasis over here. With the Soralen, yeah, with the Soralen and UVA wavelength, UVA light is given for the treatment of psoriasis. So coming back, UVA wavelength penetrates deeper into the skin, cause photoaging. So UVA wavelength causes photoaging, while UVB wavelength will cause sunburn and increased risk of malignancy. UVA produces reactive oxygen species, which will decrease the collagen production and upregulation of matrix metalloproteinases, including the collagenases that subsequently degrade the type 1 and 3 collagen and elastin. Okay, so upregulation of the matrix metalloproteinases, including the collagenases that subsequently degrade the type 1 and type 3 collagen and elastin. Pardon me. There is going to be a decreased collagen production by UVA. There will be upregulation of the matrix metalloproteinases that, including the collagenases that subsequently degrade the type 1 and type 3 collagen and elastin. Pathology: there will be thinning of epidermis, decreased subcutaneous fat, blood vessels, hair follicles, sweat ducts, and sebaceous glands, and skin atrophy. Red ridges at the dermoepidermal junction become flattened. Increased cross-linking of collagen with the deposition of collagen breakdown products, and desiccation of the stratum corneae will also be seen. Now let's talk about vascular tumors of the skin. Firstly, we'll talk about angiosarcoma, a rare blood vessel malignancy typically occurring in the head, neck, and breast areas, usually in the elderly or on sun-exposed areas. It is associated with radiation therapy and chronic post-mastectomy lymphedema. Okay, so angiosarcoma, it is a rare blood vessel malignancy typically occurring in the head, neck, and breast areas, usually elderly and sun-exposed areas. Okay, we are reading angiosarcoma with reference to the skin or the dermal angiosarcoma. You may say that associated with the radiation therapy and chronic post-mastectomy lymphedema. Hepatic angiosarcoma associated with the vinyl chloride and arsenic exposure. Okay, if it develops in the liver, so most of the time it is associated with the vinyl chloride exposure or arsenic exposure. Very aggressive and difficult to resect due to the delay in the diagnosis. What is bacillary angiomatosis? Bacillary angiomatosis is caused by an organism that we call Bartonella henselae, and that is caused by the manifestation of cat scratch disease in the immunocompromised patients. Proliferation of the blood vessels, capillaries, resulting in them forming the tumor-like masses present with a red purple papules in the skin or other organs. So this thing is basically a blood vessel tumor or blood vessel proliferation, you may say that. It is found in the AIDS patient, caused by the Bartonella infection, exposure to the cats. In immunocompetent patient, it is going to cause cat scratch disease. Cat scratch disease is just regional lymphadenopathy, which resolves with giving the antibiotics, the tetracycline mainly. But in the case of immunocompromised person, this condition can worsen to form the bacillary angiomatosis, frequently mistaken for the Kaposi sarcoma HHV8, but has neutrophilic infiltrate. Now that is very important. When we do the biopsy, we'll find neutrophilic infiltrate because it is a bacterial infection, and in the bacterial infections we find neutrophilic infiltrate. The Kaposi sarcoma is HHV8 is a virus, so in the case of viral infection we are supposed to find the lymphocytic infiltrate. So for the virus we find lymphocytic infiltrate, and for the bacteria we get neutrophilic infiltrate. Remember the difference. Now let's go to the Kaposi sarcoma. Kaposi sarcoma is endothelial malignancy, most common of the skin, but also mouth, GIT and respiratory tract, associated with HHV8 and HIV, rarely mistaken for the bacillary angiomatosis, but has lymphocytic infiltrate. Then we'll talk about cherry hemangioma or senile hemangioma. You may have seen patches like these on the skin. So what is cherry hemangioma? Small bright red papular lesions, does not regress and often multiple with age. So the most common benign vascular tumors in the adults and typically appear during the third or fourth decade of life. Light microscopy of these lesions shows proliferation of capillaries and post-capillary venules in the papillary dermis, that is benign capillary lesion. Now let's talk about strawberry hemangioma. These are benign capillary hemangiomas or infancy, as you can see in this picture. In this picture, they are on the cheek of the child. They appear in first few weeks of life in 1 by 200 births. They grow rapidly and regress spontaneously by 5 to 8 years of age. Now let's talk about cystic hygroma. It is a very important concept because cystic hygroma is associated with the Turner syndrome, and both these concepts are tested together. Lymphatic cysts lined by a thin endothelium often present at birth and most commonly located on the posterior neck and the lateral chest wall. They are associated with the Turner syndrome. Moving forward, now we'll talk about glomus tumor. So what is a glomus tumor? Okay, it is inside the nails. So benign, painful, red-blue tumor commonly found under the fingernails. Arises from modified smooth muscle cells of the thermoregulatory glomus bodies. Glomus bodies are like the areas of the skin in which the arteries are in direct connection with the veins. I guess it is an arteriovenous fistula where there is rapid blood flow, and that rapid blood flow is regulating the body temperature. So it is the glomus tumor is present inside the glomus bodies, which are thermoregulatory bodies of the body, which are thermoregulatory structures of the body. So what is glomus body? Let's see that. Glomus bodies are these structures which you can see over here. What is meant by glomus body? So the glomus body or the glomus organ is a component of the dermis layer of the skin, that is below the epidermis, involved in the body temperature regulation. The glomus body is a small arteriovenous anastomosis surrounded by a capsule of the connective tissue. Glomus bodies glomera are most numerous in the fingers and toes. So they are like something like this. So these are arteriovenous connections which are present, which are encapsulated, and they are present in the dermis. Okay, let's keep it till here. Now moving forward to the pyogenic granuloma. So pyogenic granuloma is a polypoid lobulated capillary hemangioma. Polypoid lobulated capillary hemangioma, as you can see in the picture E, this one or maybe this one, that can ulcerate and bleed, associated with the trauma and pregnancy. Then let's talk about skin infections. So bacterial infection. Firstly, we'll talk about impetigo. It is very superficial skin infection. Usually Staph aureus and Strep pyogenes can cause that, and it is highly contagious. Then honeycombed crusting will be seen. It is not very honeycombed, but if you zoom it in, so you may find honeycombed crusting. Crusting is a dry lesion, which we saw on the table as above. So bullous impetigo has bullae and is usually caused by Staph aureus. So impetigo is caused by the group A Strep pyogenes. The characteristic kind of impetigo is caused by the group A Strep, that is also called as Streptococcus pyogenes, and the Staphylococcus can cause bullous impetigo, which is the impetigo associated with bullae. Non-bullous impetigo, microbiologist Staph aureus can cause the non-bullous impetigo as well. Group A beta hemolyticus and Streptococcus or Strep pyogenes. That's one thing. The group A beta hemolytic Streptococcus or Streptococcus pyogene and Staph aureus, both of these are associated with the non-bullous impetigo. Clinical features associated with this are painful non-itchy pustules and honey-crusted lesions. Treatment is topical antibiotics, for example, mupirocin. Complications are post-streptococcal glomerulonephritis. Now let's talk about erysipelas. Erysipelas are very specific for Streptococcus pyogenes. Infections involving the upper dermis and superficial lymphatics. So upper dermis and superficial lymphatics are involved in the erysipelas. Usually in the Streptococcus pyogenes, they present with well-defined raised demarcation between the infected and normal skin. So this is the demarcation line between the infected and the normal skin. So remember this difference. And then we'll talk about cellulitis. Deeper dermal and subcutaneous infection, usually due to Staphylococcus aureus and Streptococcus pyogenes, present as red, tender, painful, swollen rash with fever. In the cellulitis, there the person is having cellulitis on the foot. Often starts with a break in the skin from trauma or recent surgery or another infection or the insect bite. It can progress to necrotizing fasciitis, that is very dangerous and very devastating condition. It can progress to necrotizing fasciitis with the necrosis of the subcutaneous tissue due to infection with the anaerobic flesh-eating bacteria. Production of carbon dioxide lead to scapetus and surgical emergency. Cellulitis is an emergency. It is a surgical emergency, and it is caused most commonly by Streptococcus aureus and Streptococcus pyogenes. Then moving forward to the abscess, as you can see over here, collection of pus from a walled-off infection within the deeper layer of the skin. Abscess, collection of pus from a walled-off infection. Okay, so it is caused by Staph aureus. Open organism is almost always Staph aureus for the subcutaneous abscesses. Why is that? We know that Staph aureus among all the staph is coagulase positive. So when it is coagulase positive, suppose we have bacteria growing over here, it will coagulate the serum around that, it will coagulate the proteins which are present around that, so there will be a walled-off abscess. That is the reason that Staph aureus infection is not spreading elsewhere or not spreading to the distant areas. But for the Streptococcus pyogenes, firstly, there is no coagulase, and secondly, they have an enzyme that is called as hyaluronidase. So hyaluronidase is an enzyme that is present in the case of Streptococcus pyogenes, and that breaks down the basement membrane of the extracellular matrix and allows the organism to spread to distant areas. So the cellulitis which is caused by the Streptococcus pyogenes or the fasciitis, that will be widespread, and that will involve a major area of the skin. Now moving forward to the necrotizing fasciitis. Deeper tissue injuries, usually the anaerobic bacteria or Streptococcus pyogenes. Staph pyogenes can cause fasciitis, or most of the time it is caused by anaerobic bacteria as well. Pain may be out of proportion to the exam finding. Now in the exam finding, you may see a small patch of the skin, that is patch of the arm that is involved in the fasciitis, but the pain will be out of proportion to that. Result in crepitus from the methane and carbon dioxide production by the flesh-eating bacteria, which can be anaerobes of Staph pyogenes, and causes bullae and a purple color to the skin. As you can see over here, there is a purple discoloration of the skin. Surgical emergency. The necrotizing fasciitis is also a surgical emergency. Talking about Staphylococcus scalded skin syndrome, as you can see in this picture. Mechanism: exotoxin destroys the keratinocyte attachment in the stratum granulosum. So Staphylococcus scalded skin syndrome, the exotoxin will destroy the keratinocyte attachment in the stratum granulosum only. So the scalded skin syndrome is limited to the stratum granulosum. Now let's see the picture. Come let's get sunburn. Okay, it is over here. Yep. So come let's get sunburn. Stratum corneum, lucidum, granulosum, spinosum, and basal. So only the stratum granulosum is involved in the case of scalded skin syndrome, that is caused by Staph aureus. So the Staph aureus, okay, so exotoxin destroys the keratinocyte attachment in the stratum granulosum only, versus the toxic epidermal necrolysis, which destroys the dermal epidermal junction. It is characterized by fever and rash. So the fever and rash will be present in the scalded skin syndrome. Then we'll have generalized erythematous. So fever and rash will be present. The rash will be generalized and erythematous, with sloughing of the upper layer of epidermis that heals completely. Positive Nikolsky sign: separation of the dermis and epidermis upon stroking of the skin. Like you press the skin, or you stretch or tug the skin a bit, and it gets detached from the underlying dermis. Seen in newborn and children, adults with rare renal insufficiency. Okay, seen in newborns and children and the adults who have renal insufficiency, they may have developed Staphylococcus scalded skin syndrome. Let's see the Nikolsky sign. Nikolsky sign. So Nikolsky sign is skin finding in which the top layer of the skin slip away from the lower layer when it is rubbed. So this is Nikolsky sign. This is a good picture. So here you can see Nikolsky sign: skin redness, fluid collects underneath the skin, and underneath the skin rubs off, leaving the red base. So red base is prominent, and the skin is scrapped off from the upper layer. Okay. Then we have what's that? The normal skin looks something like that. In the case of Staphylococcus scalded skin syndrome, the stratum granulosum, this layer stratum granulosum, the connections in the stratum granulosum are gone. Firstly, we'll have stratum corneum, and then stratum granulosum. spinosum basale, they have, forgot to write stratum lucidum. So, okay, so stratum granulosum, if there is loss of connection between the stratum granulosum, there will be separation between the stratum corneum and the granulosum. So we will scrape it off. So the upper layer, which are stratum corneum, lucidum, and granulosum, will be scraped off, while the lower layers, which are spinosum and basale, they will still be there. So the scraping off will not yield dermis directly. They will be yielding the lower layer of the skin, which are spinosum and basale. I'm sorry for the wrong information, but it is correct information now right now. So viral infection. First, we will talk about herpes. Herpes virus infection, HSV1 and HSV2 of the skin, can occur anywhere from the mucosal surface to the normal skin. These include herpes labialis on the lips, herpes genitalis on the genitalia, herpetic whitlow as depicted in this picture. It is very common among dentists because they put their fingers inside the mouth of the people, and if there is herpes infection inside the mouth of the person, so the dentist is going to get herpetic whitlow on the finger. Then we'll continue from the molluscum contagiosum in the next session. Until then, Allah Hafiz and Fi Amanillah.